Cool. So I think we will get going. So hi everyone. Thanks for joining us at, well, whatever time it is you are where you are in the world. My name's Rio Lehman. I'm a lecturer at the stats department at UCL, and I'm also one of the co-founders of Data Science for Health Equity. I will not call it its full name for the duration of this presentation. I'll call it DSxHE, so DSxHE. We affectionately call our community DSxHE. So if you hear me refer to DSxHE, that's what I'm talking about. So today is very exciting day for the community. We're officially launching our 5 themes, and hopefully throughout the presentation you'll figure out exactly what those themes are, what themes are within DSxHE, and what the community is about. So here's a rough schedule for the next hour or so, a bit less. So first I'll introduce the community, Data Science for Health Equity, and give an overview of what we're about, what we're doing, what our plans are. Then we'll have an intro, roughly kind of 4 or 5 minutes for each of our 5 initial themes. And then it's up to you if there's a particular theme that you're interested in. We're going to have little breakout rooms for each theme where you can go into the respective breakout room, and each of the theme leads will be leading their separate session for about 20 minutes or so. And then finally, we'll have like a little wrap up just to put everything together and tell you what you want, if you want to get involved, how to get involved, and so on and so forth. So that is the order of play. Next slide, please, May. So yeah, we'll start off with an introduction to DSxHE. Thanks, May. Okay, so what is DSxHE, and like why do we kind of have this community to begin with? So the kind of reason DSxHE really came about is, well, digital technology has been used in all places in the healthcare systems, from biomedical research and to like the doctor's office and electronic health records, to the operating room and like AI assisted technologies, to public health management and protection, and so on and so forth. And I think it's clear that advances in data science, and we mean data science very broadly, so statistics, machine learning, AI, everything. It's clear that these technologies hold great potential for improving health across the board. And there's lots of examples of AI technologies being used, for example, in breast cancer screening that can catch cancer tumors that doctors might have missed. But the question is, how do we ensure that the entire healthcare system benefits from these technologies, specifically so that people, especially those that have been part of subgroups that have been historically underserved, have the access and quality of care that everyone really deserves. So our starting point is that it's not enough to just kind of close our eyes and hope for the best. There's plenty of examples of data-driven technologies being deployed in healthcare systems which just serve to perpetuate inequalities or even make them worse. And so this is where the DSxHE community comes in. And we're hoping that by explicitly applying a health equity lens to these issues, our goal is to make sure that the latest research and innovations in data science benefit the health of everyone. Next slide, please, May. So who are we? Very, very broad church, basically, cross-sector and cross-discipline, open to everyone who's got an interest in data science, health equity, ethics, and everything in between. So what that means in practice is, the health and care professionals, whether that's clinicians or people working in public health who want to use data to improve practice, academics and researchers working in fairness, ethics, statistics, machine learning, public health, health inequalities, epidemiology, policymakers who want to adopt and implement data-driven solutions, people working in the private sector, those developing products for clinical or public health environments, funders looking to support projects and programs that enhance health equity, and also media, public media folks who want to understand more of the challenges and inform the public debate around health inequalities. So hopefully that covers anyone who might have an interest in this kind of, admittedly fairly niche but important intersection. Next slide, please. So it's been just over a year since our soft launch. I didn't realize it was the 23rd of September is kind of DSxHE's kind of birthday. So I've put a little birthday cake there for us. So it's been a very busy first year. We've assembled a team of fantastic organizers. There's about 13 or 14 volunteer organizers who just give up their time to help run the community activities and make sure that everything is going smoothly behind the scenes. We held a hybrid launch event back in April, which was very successful. We had lots of people attending online and in person with really cool food trucks. And we've had like a pretty good, decent social media following on Twitter and Slack. We actually even got mentioned in iNews a couple of months ago, which was pretty cool. What today is about, we're kicking off our 5 themes. And we've also secured Sir Michael Marmot, the health equity guru, as our team mascot. Next slide, please, May. So this is hopefully that's not too small for you guys to read. This is just after our first kind of information session where we tweeted at Sir Michael Marmot if he could be our team mascot, and he replied that it would be an honor. I'm not sure what that actually means in terms of the community, but he did come to give the keynote at our launch event, so maybe there's something in that. Next slide, please. So I've spoken a bit about the community and what the wider community is about, but today is about the DSxHE themes. So what are our themes? So while the community's activities isn't restrictive in terms of the range of topics that we're interested in and that we cover, we also have a few of these kind of focus areas which we dive into more deeply. And the idea is that these are led by passionate members of the community from whom you'll hear today, who want to essentially tap into the wider community that they might not necessarily have access through their usual network. So the idea is to source ideas and collaborations from a broader mix of individuals and start to bridge the gaps between the sectors and disciplines where ultimately everyone's working towards the same goal, maybe using slightly different language and with slightly kind of different domains of expertise. But we think by bringing these people together, we can make more kind of positive progress towards reducing some of these health inequalities. So today you'll hear from 5 of our initial themes, but we're not limited to any of those 5 themes. So if you have a particular area that you're very interested in and that you would like to use the DSxHE community to augment your work, then please do get in touch, and we'll talk a bit more about that later. So I think that's it from me. I am going to pass over to May to lead us through the theme intros for today.
Thanks very much, Bill. So along with Bill, I'm May, and along with Bill and Alison, whom you hear from later, the 3 of us tend to work on theme coordination. We help out with the organization of DSxHE, and I won't be talking long because I think our 5 themes should take center stage. So each of the 5 themes will spend the next 20 minutes or so giving an introduction to their themes in this order. And afterwards, you go into breakout rooms and hear more about the themes and also discuss more about what you'd like to do in those themes. So we'll start off with genomics, where Maxine is the theme lead.
Perfect. Thanks, Maybury. So hi all, thanks very much for coming. So my name is Maxine McIntosh. If my day job, I run an initiative at Genomics England called DSxData, which is all around how we can improve the ancestral diversity of the genetic data that we have. And I decided to kind of set up a project within, set up a theme because whilst it's very nice working at Genomics England, there's loads of other organizations that I want to work with and that need to be around the table to address this problem. So it's been really nice for me to kind of have a mechanism to that, like lots of flexibility and freedom. And it's nice to see a few friendly faces that I've interacted with across the theme already. So I can see Aishani from Benevolent AI in the audience as well. So for those who don't really know much about genomics, I'm only like a year into my genetics voyage and journey of discovery. The kind of big inequality issue that kind of characterizes the problem is the fact that in genetic studies, the populations that dominate these are really largely comprised of individuals from European ancestry. So the kind of graph on the right, even though it's quite small, you can just see there's lots of red. And what that graph is showing is that the number of individuals contributing to GWAS studies, which is a very kind of common popular type of genetic study, has really increased exponentially over time. Just loads more people are contributing to genetic studies. So, data sets getting bigger and bigger and bigger. But the number of and proportion of people of European ancestries is also getting bigger. So whilst there's been a kind of meager improvement in contributions for individuals of East Asian ancestry, really it's mostly still on Europeans. And that's a problem because it means that all the kind of discoveries that we do, the models that we build, don't always, but they tend to therefore predominantly only work for individuals of European ancestry. And obviously, as those everyone here will know, Europeans do not dominate the world. So that's a kind of data problem. There's loads of initiatives out there already that exist to address data inequalities and to collect more data, look to do whole genome sequencing. And there's, I guess, been an increasing awareness of the structural and wider systemic factors that exist that kind of perpetuate this problem. So global inequalities in funding and workforce challenges. We felt there was a kind of a wee bit of a gap in the sense of, if you are an individual working in this space, what can you do differently right now on the existing data that you have to make the impacts of the imbalanced data sets less bad? And that was kind of the inception of this theme. And so this theme is going to be hosting its kind of first thing is going to be hosting a project called Link 23. And Link 23, sorry, can you go back a slide? And so Link 23 is an initiative which aims to curate, build, implement, and spread tools that make genomics as accessible as possible. So for us, a tool is everything from like a software package in R to a handbook with how you speak to individuals from Papua New Guinea about genomics. Like if it's a practical dimension, it counts as a tool for us. And the whole idea is that if you are a practitioner in this space, you can kind of walk away with kind of concrete, tangible things that you can do right now to change your practice. So that's kind of the main thing that we're doing in theme, but also we're kind of going to be doing hosting some kind of webinars also talking about genomic equity. Next slide. So Link 23 is due to kind of launch at as a project at the beginning of October. So we'll be kind of coordinating with all the partners on that. Our first few months are really going to be around kind of co-design of how the community operates, everything from like the taxonomy of the data to the metadata that the tools need to what are the standards that a tool might need in order to be uploaded into Link 23. All of that is up for grabs. And the idea is that kind of come the 1st of January 2023, we can do our first challenges in Link 23. So what we're kind of hoping for that is that organizations and initiatives that have a big kind of genomic equity challenge for us to work on, we can all come together kind of globally and work and hack and build and design together to solve those problems. And then whatever we create as a byproduct of those little collaborative activities then become publicly available and are made open source. Some asks from me are, we're currently building the organizing team. We've got kind of a small organizing team, but we're looking to kind of get bigger. We're looking for partners to join. What that means to be a partner, I can discuss later. Please submit a tool. If you've got a model or a tool or a handbook, contribute it to Link 23. And if you have a really knotty problem in genomic equity, then we're really looking to find really meaningful problems that we can deploy people against. So if you want to come and hang out with me in my breakout room, I've basically got like 4 different post-its that are like discussion topics. So depending on who turns up, we'll either talk about like tool taxonomies, we'll talk about governance of Link 23 project, we'll talk about important challenges to work on. So we'll keep it like flexible depending on who comes to the breakout room, but obviously it'll be loads of fun. And you get to hang out with me for 20 minutes. Thanks.
Excellent. Thanks, Maxine. Very quickly moving on to infectious diseases. So our next team lead is Dr. Palusha Khan. And unfortunately, she won't be able to make it live today. She's facing intermittent power supply. So I'll swap over to a pre-recording that she's kindly done for us for her introduction. When I can find it.
May, we can't hear the sound. I think you might have to share audio from your screen as well.
London School of Hygiene and Tropical Medicine, and I'm currently... Hi everybody, I'm so sorry that I can't be with you live in person today. I'm currently based out in rural KwaZulu-Natal, and we're having real issues with load shedding, which makes our internet connectivity really ropey. Anyway, so I am Palwa Shah, and I am a clinical associate professor in infectious disease epidemiology at the London School of Hygiene and Tropical Medicine, and I'm currently seconded here to the Africa Health Research Institute in rural KwaZulu-Natal in South Africa to head up the health informatics section of the data science unit. So that's me, and I find myself as the theme lead. So I'm just going to quickly take you through a few slides to introduce the theme and actually really request help, but I'll come to that in a minute. Just by way of introduction, I think it's safe to say that in general, we focused on the biomedical paradigm when thinking about infectious diseases. I think the HIV field has been better at taking a social lens perspective with respect to understanding why HIV is distributed in populations, but in general, across the board, we haven't really taken into account the role of social inequities in driving a lot of distributions of infectious diseases in different populations. What we'd really like to do with this theme is actually to explore and highlight the critical causal role of socially driven inequities, and actually seeing if we can actually quantify those with respect to the risk of exposure to infectious pathogens, and then also the risk of a poor outcome of if somebody then goes on to develop disease given infection. And I'm just going to highlight here that you know, it's something that I've come across very recently in my line of work, which is thinking through as to how different diseases are distributed in populations. And this is Nancy Krieger's eco-social theory, which takes into account levels, pathways, and powers. And actually, it's a really good way of thinking through how social inequities might be driving the distribution of infectious diseases in different populations. So just going to put that there. So some of the work that we're hoping to do as part of this theme is to undertake some interdisciplinary webinars. So obviously including infectious disease clinicians, epidemiologists, surveillance teams, social scientists, behavioral scientists. So just anyone who's interested in the, I've forgotten a whole bunch of people, but I'm just saying that actually one of the things is that I think we need to be doing some sort of webinars and also workshops. And one of the things that I did think would be really helpful to start off, and I'm open to ideas, is undertaking a stakeholder survey, because one of the things that came to light was that we might have good surveillance data for different infectious diseases, but again, focused on the biomedical paradigm, and we've collected very little data relevant to social and demographic. Well, I suppose we get demographic information, but actually we have very little relevant data that allows us to look at any social inequities with respect to infectious diseases. I'm just going to quickly show you just sort of almost as an application of thinking through in my field of research, which is mostly in TB epidemiology, and TB is the quintessentially socially driven disease. You know, we do look at the life course with respect to when somebody's born through to death, and that impacts their risk of exposure and then disease. Also risk fact, you know, sort of risk is associated at different levels. So individual level, household level, societal level, environmental level. The complication also comes in because we also have a multi-dimensional level. So almost like a birth cohort level, and what you're exposed to, you know, what you're exposed to at birth in the 1980s will be different to what potentially you might be exposed to at birth now in the 2020s. And the other thing that needs to be taken into account, which definitely probably is driven by social inequities, are secular changes, cultural, societal, environmental, climate changes that will obviously increase or decrease your risk of exposure to Mycobacterium tuberculosis, and then also how things are distributed through space. So super complex. And for me, this just highlights the fact that ignoring these multi-levels, including societal and social inequities, means that we'll never really get on top of addressing the epidemic. The issue is it's really difficult to do from a data collection perspective and from an analytical perspective. And that's why sort of a network such as Data Science for Health Equity is super important, because it does bring together a whole group of different people who work in these fields and sort of breaks down the silos. I'm just going to quickly just skip through this and just say that actually the times, they are changing, and there's a much more focus on equity post-COVID. As we can see, there's now publications that show you sort of have guidelines to introduce this equity lens into if you're undertaking computational modeling of infectious diseases. I do think the interdisciplinarity is finally coming of age, because we've now got novel statistical methods which allow us to sort of analyze the complexity of the pathogen, the host, and the environment. And then I think it's really fair to say that we've now finally realized that without the social lens, we only have a partial view of transmission mechanisms of a whole host of infectious disease pathogens. And then without that kind of understanding, we definitely won't be able to target efficiently and effectively any interventions to reduce transmission and improve health outcomes. And so one of the things that I do think we need to do is to advocate for better, more systematic data collection and or data integration, because the point was recently made that actually there are a huge number of data sources out there. So we do need a mechanism, a network that allows us to kind of bring together data to address some of these questions. And I'm just going to stop there, a whistle-stop tour. And I just want to say, please do get in touch. I mean, it's a very embryonic stage. I find myself here as theme lead. I am very keen for people to get involved and help and potentially take over and go forth. So do get in touch, and thank you. And I'm sorry again that I'm not there in person. Okay, bye.
Great. Thanks, Patty. And quickly moving on then to social determinants of health, our third theme, and Dr. Alicia Davies will take us through her theme.
Hi everyone, I'm Alicia Davis. I'm working at the minute part-time at the Alan Turing Institute as a health theme lead for one of their programs. And I'm also a consultant in public health and the head of research at Public Health Wales. So I'm in Wales at the minute. So the social determinants of health, if you go to the next slide, thanks May. The rationale for this is that often health, just as was being reflected, is considered as an individual's behaviours and risk, whether that's genetic or other factors. But actually more than 50% of an individual's health is due to the social determinants of health. So that can be factors such as those illustrated in that Dahlgren and Whitbread rainbow diagram on the right hand side of your screen. So it can be your work environment, level of education, unemployment, access to clean water, access to good and secure housing. And those conditions in which people live and work and grow are really important, and they're the underlying factors that contribute to someone's health. It's reflected from way back into the 19th century, whenever improving sanitation and reducing overcrowding were recognised as being really important to prevent the spread of infectious diseases. And today, our understanding of the social determinants in the round about education and employment, we're getting there, but actually we can do much more. The aim of this stream is really about trying to bring in that data science element into helping to better understand and direct action on the social determinants of health through better data, better tools, better methods in an open and transparent way. The figure at the bottom is actually from the World Health Organization's report on health equity across many different countries, looking at national data sources. And you can see that across 3 different dimensions of health, whether that's self-reported health, mental health, or life satisfaction, only 10% of the difference or the gap in those outcomes between the most and the least deprived was due to health service type indicators in the respective countries. Over 40% in some, about 30% was due to income insecurity and social protection. So things like the benefit system that we have here in the UK. About a third was living conditions, but also social and human capital, and how we link with others is really important, as was employment and working conditions. So how can we better understand some of those factors and bring those into the work that we do? Next slide, May. Thanks. Now, there's a growing appreciation of the social determinants of health. There's no doubt about that. There was that WHO piece, there's a WHO commission on the social determinants of health. Michael Marmot, huge champion about the social determinants of health. And there are parts of the system, for example, there's examples in the US where they're trying to look at where they can better capture data on the social determinants of health to improve decision making, not just in healthcare sectors, but also health policy as well too. And to give you one example, there's an example on a recent review was looking at risk prediction tools for cardiovascular disease. And over 3,000 different tools this review found, and actually the consideration of social factors was really, really poor. So things like working conditions, level of literacy was a key gap. And actually some of those factors are really important when it comes to trying to support patients if you are thinking about how to better reduce and manage an individual's at an individual level a risk factor. So on the horizon for the social determinants of health theme within data science and health equity, it is a huge topic. So what we'd like to start with, I was thinking more about sharing some examples where data science has been applied to the social determinants of health. Thinking about putting together those papers or examples or tools on an open platform, but also having some webinars and discussions about actually what really makes this really difficult. The second is about trying to better identify some of those challenges about using social determinants data in our health research, whether that's research for healthcare systems or policy analysis, like synthetic populations or micro simulation of different policy actions and the impact on health equity. So we'd like to do something along the lines of a workshop and refining some of those goals and building that network. So there's a few asks down there at the bottom, and we'll pick a bit more of that and have a bit more of a discussion about it in the breakout room. So come and join me in the social determinants of health. Thanks, May.
Brilliant, thanks, Alicia. Okay. And then quickly moving on to standards for health data equity. And this would be Doctors Xiao and Joe.
Thanks, May, and thanks everyone else on the call. So my name is Joe. I'm an anaesthetic and intensive care doctor and a PhD student in digital health equity based in Birmingham. And also on the call is Xiao. She's an ophthalmology doctor, postdoctoral researcher, and AI equity and safety guru, also based in Birmingham with our team. And we're going to be introducing our theme today, which is on standards for health data equity. So next slide, please. The first thing to get out of the way, what even are standards? What do they mean? Well, I really like the quote from the ISO. Basically, it says that standards are a formula that describes the best way of doing something. And on the next slide, please. Essentially, they're an agreed set of norms. And simply put, when we say something conforms to a set of standards, we basically can have trust that it will be as expected. And that thing might be a product, it might be an individual, it might be an organization, it might be a government, it might be anything else. The long and short of it is that we, as the consumer of that, can somewhat devolve our thinking and somewhat devolve our kind of judgment, because we can trust another organization has
said that this thing will work as we expect. And there are some organizations around the world that will mark products to say they conform to standards. But not all standards are set in stone and kind of have legal basis. Sometimes standards can act more as a guidance or as a best practice statement. And in that respect, they're not just necessarily a stick, but they might be the carrot, a kind of a way of encouraging best practice to make sure that products and things we do in health research generally move forwards and benefit wider society. Next slide, please. Just a quick plug for the Standing Together project, which is kind of how I got into this space. So Standing Together is a project based out of the University of Birmingham and University Hospitals Birmingham, which aims to develop standards which will improve generalizability and transparency of healthcare data sets. And through systematic reviews of existing healthcare standards, working with the community through a two-stage Delphi study, and then interviews with key stakeholders, we're basically going to develop a set of standards that we hope are genuinely useful and actually implementable, and push us towards a world where healthcare AI is equitable and safe for everyone. Next slide, please. So there's a lot of people out there, us included, doing great work on setting standards. So we want our theme to come at this from a slightly different angle. We want to focus on taking these standards which are being developed and actually working on adoption of those standards. If we use the analogy of drug development, it's all well and good developing a great new drug that's in a laboratory setting, but if that can never be translated into clinical practice, there's really no point that having happened. We've wasted our time, we've wasted our money. Similarly, there's a lot of great standards out there, great work that people have done that maybe is invisible, hard to find, or hard to implement. And so our theme is going to basically try and improve that situation. Now, these are just some of the sub-themes that we think we might want to adopt as part of our theme, just some ideas, making them easy to find, helping interpretability, and making the economic argument for adoption. But we're really keen to hear your ideas about how we can push standards forwards, how we can make them easier to adopt by the community. Next slide, please. So what's next and what do we need from the wider DSxHE community? Well, we're open to collaboration offers from today. So come and join us in the breakout rooms if you like. We're planning to develop our theme activity streams. So working on those previous ideas and maybe introducing new ones over the latter part of this year, and then probably having a launch event either later this year or early next year. In terms of what we need from you, well, join our team, either as members or as sub-theme leads. We'd love to have your ideas. I promise we'll give you credit for them. And we'll let you adopt them. And lastly, if you have time, please do contribute to our Delphi study as part of Standing Together. There's a QR code and a cheeky link that's there for you.
Excellent. Thanks very much, Joe. And then very speedily, our last theme is on statistical methods, headed by yours truly, Brio. I will keep it very brief. The statistical methods theme, the kind of reasoning behind it is that, data has the power to shed light on, all the complex factors underlying health inequalities, whether that's biological, cultural, social, economical, and all these different factors can contribute to inequalities and the determinants of health, which Alicia touched on. It's important to be able to understand what is driving these inequalities, and by using diverse data sets, we might be able to kind of disentangle these different factors. However, the statistical methods needed to do this can be quite sophisticated, and we need to have drive research in that direction to make sure that we can gain these insights from the data that's available. However, on the other hand, there is the danger of, if we're thinking about machine learning or AI systems, there's the danger of entrenching disparities through clinical algorithms that are trained on existing biased biomedical data sets. So Maxine touched on it. The example from genetics is that 90% or so of human genetic samples are from people of European ancestry. So if you're training algorithms based on the data that's already available, it's going to perform a lot better on people that have basically already been captured in data sets, with the risk of making disparities worse. So it's really important to really take like an equity angle to the statistical methods that we're developing to make sure that we're not perpetuating or exacerbating existing inequalities. Next slide, please. So
this theme is quite research focused. The idea is that we want to develop better statistical methods and machine learning methods. And the way we want to do that is by essentially driving research in a certain direction, and to try and share knowledge across the different groups across the world and across disciplines that are working on some of these topics in many different kind of academic departments. So the rough plan, which I'll touch a lot more on during the breakout room, is we've got a monthly webinar series that's going to start next month, and we've already got a couple of speakers lined up. We're going to have a fortnightly reading group looking at some of the latest and kind of foundational papers in the field. And we're also going to do a kind of field landscaping exercise to try and answer the question of which researchers or groups are working on statistical machine learning methods which are either applied to or which might be relevant to health equity, just to get an idea of who's working on what, and to try and bring these people together, build collaborations, and so on and so forth. In terms of the asks, already got a great team of four organizers. You'll meet them in the breakout room. Please come and attend our events. These events, their success depends on the audience and then sharing this knowledge. If you are a researcher, or if you know of researchers working on some of these problems, let us know. And finally, we'd love for you to tell us your statistical challenges. So if you're an applied researcher and you're coming across problems with your data that you don't know how to solve, or you don't know which statistical methods to use, let us know. So I'll pause there. Come and join the breakout room if you want to know more.
It's like a slightly random thing. I think I got like booted out of the whole event.
I'm sorry to hear that.
Have you done like a Breaking Bad news talk or something?
I think Alison has just got dropped, so I will take this outro. Thanks everyone for coming. So if you want to stay involved, which hopefully you do, if you want to join the theme, speak to the theme leads about how you can get involved. Again, if you've got ideas for events or partnerships for any of the specific themes, then talk to the theme leads. They're the kind of first point of contact in terms of getting involved with each of the theme activities. If you would like to start your own theme within DSxHE, so again, just like another kind of specific focus area, then speak to either Alison, May, or myself, and we can give you a bit more information about exactly what that means. Next slide, please. So yeah, that's it. Thank you so much for joining. Sorry, the breakouts were a little bit rushed. Hopefully they were still productive for you. We will be posting the recording of this last hour or so on our blog, on our website. So have keep an eye out for that. If you are ready to kind of engage with the community, there's a few different ways you can do that. Join our Slack. I've just posted a link to join the Slack in the chat. Sign up to our newsletter. So you can, if you go to our homepage and scroll all the way to the bottom, you can sign up to our newsletter and mailing list. And finally, you can of course follow us on Twitter if you're that way minded. Amazing. So we are just on half past the hour. Thank you everyone for coming. It's great to see so many faces. And yeah, bye. Take care.
Thanks.
Thanks all.
Bye.
Bye. Thank you.